This is Hubwonk. I'm Joe Selvaggi. Welcome to Hubwonk, a podcast of Pioneer Institute, a think tank in Boston. When trying to address the more than $4 trillion annual cost of U.S. healthcare, policymakers often target the nearly $600 billion cost of drugs. While drug manufacturers can point to the high cost of development and testing as justification for their prices, generic drugs, those that have gone off patent protection, seldom charge prices that substantially exceed production cost. Indeed, according to the Government Accountability Office, generics saved the U.S. healthcare system more than $1 trillion from 1999 to 2010. Recently, however, price spikes, anti-competitive practices, and supply chain complexities have showcased weaknesses and inefficiencies in the generic market, such as the fact that 1 in 5 generic drugs doubled in price between 2014 and 2017. Seeing this uptick in generic pricing as a business opportunity, billionaire and Shark Tank investor Mark Cuban in January of this year launched the Mark Cuban Cost Plus Drug Company, selling more than 100 generic prescription drugs online, some at substantially lower than average market prices. His direct-to-consumer model, if successful, could substantially disrupt the generic market, saving billions and offering low-income consumers access to once cost-prohibitive drugs. Why do the prices of many generic drugs still substantially exceed costs? Who stands to benefit from direct-to-consumer innovations? And how can patients and policymakers work to ensure this new model is embraced by those most in need? My guest today is Dr. Hussain Lalani, a clinical research fellow and internist at Brigham and Women's Hospital. In a research piece recently published in the Annals of Internal Medicine entitled Potential Medicare Part D Savings on Generic Drugs from the Mark Cuban Cost Plus Drug Company, Dr. Lalani's examined the potential $100 billion cost savings were Medicare to purchase drugs offered from Mark Cuban's company. We will discuss how the inner workings of our healthcare system created this opportunity for Mr. Cuban's model, how far this model could go toward saving money for U.S. drug consumers, and what steps policymakers and individuals can take to encourage a robust uptake of this innovative model. When I return, I'll be joined by Brigham and Women's Hospital, Dr. Hussain Lalani. Okay, we're back. This is Hubwonk. I'm Joe Selvaggi, and I'm now pleased to be joined by internist and researcher, Dr. Hussain Lalani. Welcome to Hubwonk, Hussain.
Thanks so much for having me, Joe.
All right, this is a fairly complex topic that deserves to be taken apart for our listeners piece by piece. Many of them are not healthcare system experts. So let's start at the beginning. We all agree that I think it's roughly $600 billion a year that the U.S. spends on drugs and medicine. So we're not going to today focus in on new drugs and the research and development that goes into new drugs, but rather those for which the patent has expired, or so-called generic drugs. So let's start at the beginning and talk about generic drugs. How does a drug go from being patent protected to generic?
Thanks, Joe. That's a great question. You know, the Hatch-Waxman Act in 1984 is really established the kind of the modern system for generic drug regulation in the United States. So companies come forward with a brand name product, that patent eventually expires, and generic companies are then required to prove that their drug is chemically bioequivalent to the original brand name drug. And it goes through an extensive process at the FDA that has been simplified, and it's known as the Abbreviated New Drug Application, or the ANDA process. And that is the process that all drug companies, generic drug companies that want to bring a new drug to market have to go through. And once they're able to prove that the drugs are bioequivalent and meet the standard, then they are able to market that drug. But there are some caveats that make it challenging to do that sometimes.
Okay, so I just one step at a time. So, for those of us who are more versed in economics than in medicine, a generic by that standard, and it seems like the government actually has tried to make it as easy as possible for others to produce this thing. It's more or less a commodity. In other words, regardless of who produces it, it has the same efficacy and safety regardless of its origin. Is that fair to say?
Yeah, there's no formal requirement anymore to prove safety and efficacy for the generic drugs, but it is the same chemical ingredient. and they just have, there's ways to prove that the two drugs are bioequivalent, or that they pretty much produce the same levels in the blood, and that often satisfies that requirement.
So if we're talking about somewhat generic commodity, and we have a clear path to give producers the opportunity to make this drug, in theory, market forces would suggest that because of competition, the cost of the drug would be relatively small, given that the drugs are known to be relatively cheap to produce. They're expensive to develop, but relatively cheap to produce. Is it the case that generics in general are very, very, very cheap?
Yeah, for the majority of generics, the prices have come down and over time, and they can be fairly inexpensive to produce. But there are some generic products that can still have substantial manufacturing costs. So it's hard to generalize entirely, but in general, yeah, the costs are relatively low for production, and they have been dropping. We've seen over the last just 2 years as well.
Okay, let's give our listeners a sense of how big the generic market is. You mentioned it, I think it was 1984. I don't remember the name of the act, but it effectively described terms of drugs coming off patent and into generic. I mentioned $600 billion tab for drugs. How much of that in numbers and in dollars do generics represent? Is it a big portion or a relatively small portion?
Yeah, it's actually a pretty small portion. So the way I like to think about it is about 90% of all prescriptions that are filled are generics, but they only represent about 20% of the overall spending of the health system, and of the overall health spending. And that's about, on average, $1 a day or less for those generic medicines. When you contrast that to brand name medicines are about 10% of all prescriptions, but they make up the vast majority, about 80% of overall spending. And we know that they cost, on average, about $20 a day or so, or more.
So the effect of generics actually does work. But what we're going to talk about today is, despite the fact that in theory, generics should offer very little profit motive for price gouging. There's no, competition would suggest one wouldn't be able to do this. And yet we're going to talk about today a innovation in generics whereby someone has entered the market and offered drugs potentially substantially less in the generic world. So let's start with which drugs right now that are generic are commanding a large enough profit margin to justify we'll get to it, Mark Cuban's entry. How is it that we've gotten here? How is it that there's an opportunity to compete in the generic world?
So generic drugs are produced, as you mentioned, by generic manufacturers, and then they must be delivered or distributed to the people. So somehow the drug is made, and then it needs to make it to the patient, the consumer, at the pharmacy. And over the years, there has been a complex distribution supply chain that has developed to distribute these drugs. And that includes a number of actors along the way. So there's distributors or wholesalers that work with manufacturers. There's then the pharmacies that directly buy from those distributors. There's the pharmacy benefit managers that negotiate on behalf of insurance companies. And there are the insurance companies who pay some portion of these drugs, the drug costs, for their beneficiaries who have the plan. So as you can see, there's kind of a number of actors along the way in the current market, in the supply chain market, that all take a share of what the cost ends up being to patients. So it's not just the cost of producing the drug that we have to pay for. And so that's part of in our latest research paper, where we are able to somewhat isolate what happens when a new company like the Mark Cuban Cost Plus Drugs Company comes in and purchases drugs directly from manufacturers and then sells them directly to the consumers without having all of the other actors in the middle of that process in the supply chain. So that is an important thing to be mindful of. And there are also some barriers that keep the generic costs high for certain drugs. Not every generic drug has a strong market. There is limited competition for a small number of drugs, about 5% or so of drugs. And then there's also ingredient shortages that can lead to price spikes that we have seen in recent time as well.
So what you're saying is it's not a function of producers charging a premium for a generic, but rather it's the process. It's getting from the producer to the consumer, this labyrinth of process. We on this podcast have explored why or how PBMs contribute so much cost to the system, despite their promise to advocate for lower costs. Of course, insurance companies, ours is an insurance-driven healthcare system, so we're familiar with that. So I think our audience is well acquainted with all the reasons why healthcare is so expensive. So let's stipulate that it's a very lengthy process from getting from producer to consumer. So let's dive deeply into the research you've done into Mark Cuban's disruption. Given that all these drugs are prescribed drugs, and given that we're now getting more and more comfortable with going from the consumer directly to producers, a la internet and Amazon, these sort of things, has this direct-to-consumer model been tried before? And if it has, why hasn't it failed? Why hasn't it succeeded in the past? Why have we allowed so many intermediaries to drive up our costs?
Yeah, there have been quite a few direct-to-consumer companies that have offered low-cost generic medicines. The most popular one that people may be familiar with is Walmart. Back in 2006, Walmart launched the $4 list, which now includes about 100 drugs that they sell at anywhere from $4 to $15. And direct to consumer, you can just go directly to the pharmacy and pick that up. And there are other chains, drugstores as well, that have started to offer discounts for low-cost generics. That includes Costco with their prescription drug savings program. I believe Kroger also has a program like this. And since then, in 2011, we also saw the introduction of a slightly different market in a sort of, we saw the introduction of a new sort of model to have lower cost generics, which was through coupons. And that was GoodRx in 2011, where you can get hundreds to thousands of different coupons for various different drugs at any number of pharmacies in your zip code to lower the costs of those drugs. The tricky thing is it depends on the zip code that you're in, and the prices can really vary by the drug. So there have been a number of previous innovations to try and lower the cost for certain prescription drugs, generic drugs. But this company, the Mark Cuban company, has started to gain a lot more, has started to gain a lot more attention in the media, in part, I think, because of Mark Cuban and his stature, but also because they are starting to cover what looks to be a larger number of generic drugs than what Walmart and Costco have at the moment.
Well, we all know Mark Cuban. He's well known as both a billionaire and one of the panelists, I guess, on Shark Tank. So he's a wise investor. So he's seen opportunity here. So if you're saying there's not a lot of money I think his ambition is ultimately to produce these drugs. I think he's building something down in, is it Austin or Dallas, Texas, where the chemicals go in one door and the drugs come out the other. So he's, total vertical integration. What is it unique, and what do you see as the opportunity or the addressable market for his particular model? How is it so much different than the others you mentioned?
The main thing that's different about the Mark Cuban Cost Plus Drugs company is the promise, and so far the delivery of complete price transparency for all their drugs. You can literally go to their website and type in the drug that you need. If they have it, then you'll be able to see what the cost is. And it very clearly breaks down the cost, which is the cost that they pay to purchase the drug, which they call the manufacturing cost. It's really like the purchasing cost, plus 15% of a margin that they take, and then $3 for a pharmacy dispensing fee. And then whatever price you see there, you can adjust it based on the quantity that you need and the dose that you need. And then don't forget to add the $5 flat rate of shipping. And that's the cost of the medicine. And it's the first time that we have seen the costs of a specific generic drug broken down that simply. And so that in itself is something unique, and it's helping us to get a sense for how much certain generics drugs actually cost and the cost of distributing those drugs. And we're starting to learn more as more drugs come out.
So price transparency is a big part of our formula. Our prescription, I'll use a medical term for helping to reform the medical community, price transparency, letting consumers understand where the money's going and who's producing what for what price so they can choose. I want to dive into where what the, let's say, addressable market, what is it sky's the limit? Could literally every drug be subject to this new model where ultimately we would know the price of everything?
Well, I wish that was the case for all drugs. That would be amazing. I like to say often that, as doctors, we prescribe medicines, but we don't really know the cost of the drugs we prescribe often, unless they're commonly used available drugs on some of these direct-to-consumer platforms that we talked about. But it is possible that if the company is able to negotiate with manufacturers for the vast majority of drugs, they may be able to have thousands of generic drugs, which I think is part of what it sounds like they're trying to do. And so that if they were able to achieve that, we would then have a better sense of how much those generic drugs cost. It would be great to know how much the brand name drugs cost, since those are the ones that are the most challenging for patients to afford. And so.
Yeah, sure. Now, when you talk about brand name, you're not talking about ones that are still on patent, are you?
I am, yeah.
Okay. All right. So again, I don't want to go too deep into that, but I mean, sort of an economist might justify the fact that something on patent is not expensive because the price to produce, but rather you're in a sense clawing back the money it took to develop the drug in the first place, right? So it's a different market dynamic. It's sort of you're paying for past research rather than current production. I mean,
well, I would say that the only tricky part where this becomes relevant is that there are, and this is really unfortunate, but it is a reality. We have seen brand name manufacturers making it hard for generic manufacturers to come to market through what's called pay for delay deals. If you may be familiar, it's where
we haven't covered that. So let's go there.
Yeah. So this is actually. It's really messed up, but it has been investigated by the Federal Trade Commission, and there has been a number of both accusations and convictions of drug companies that have paid generic companies to not come to market, essentially preserving their monopoly and allowing them to continue selling their drug without any competition. Lipitor is a really good case of that. So Pfizer is the maker of Lipitor, and they did admit to doing this, where they essentially paid off their competition for a few years around 2008, and that allowed them to continue selling the drug for about, I think, close to 2 additional years without any competition, and that then kept the price high for consumers. But there are a couple other sort of challenges to this process, and one of them, where it makes it hard for generics to come to market, is what's called these patent thickets. I'm not sure if you guys have covered that before, but it's this idea where a drug company can patent a variety of different minor processes or aspects of drug development, but then extend the length of their monopoly protection. So, I would say that these sort of market forces, it's not really a free market for those types of drugs, as we know. And sadly, the thought always, I think the thinking, at least in the theory of these policies, was that, yes, a drug will have exclusivity for some period of time for the innovation. And then after that, the drug will become more affordable for patients. And while we have seen that in many cases, there are a number of cases where that gets delayed or is actually really hard to produce a competitor because of these kind of anti-competitive behaviors that have not been very well addressed, unfortunately, in our current market, and that then ends up leading patients to struggle and suffer with the cost.
Well, in earlier shows, we have actually highlighted not necessarily the drug companies, but the intermediaries, and you mentioned them earlier in the show, PBMs, insurance companies, that sort of thing. Let's talk about how they might thwart the effort to reduce the cost to consumers. As they say, one person's waste is another person's income. So I'm sure that cutting out and going direct obviates the need for insurance and if you're going direct, you're not using insurance. I've got that right? If I'm going to Mark Cuban, I'm not making an insurance claim. So describe for me, how might these intermediaries defend their position as part of the process between the consumer and the producer?
Yeah. Delivering any kind of good has some basic costs. So, whether it's gasoline or t-shirts or food, there is some cost that we as consumers, I think, understand that will be required to transport the drug from, location A to B and to then, make that accessible. But notwithstanding, there are a number of actors kind of in the supply chain that have the ability to both deliver the drug, but also capitalize on it being on its production and its delivery process. So, I think that I'm not sure how they would necessarily defend themselves, but they may say that, they're paying for the cost of what it takes to get drug A to drug B. And the thing to keep in mind that is often discussed in kind of in the lay press and about pharmacy benefit managers and insurers is that, this concept of rebates, but that doesn't really apply to generic drugs. And we restricted our sort of our analysis to really generic drugs. And so in this case, there really are little to no of these transfers happening in terms of rebates between manufacturers and pharmacy benefit managers. So, it's a little bit different than with brand name drugs.
So let me ask you a hypothetical. If I can go to Mark Cuban and the drug is $20, right? And I can go through my insurance company, then ultimately it's on the PBM's formulary, and it's $50, but I get a $40 discount, or I can take the $10 I spend through my insurance company and apply it to my deductibles. Aren't I incentivized then to avoid going to Mark Cuban and instead going through my insurance company, because ultimately the cost is lower to me, even though it's higher to the system? That's how I can imagine I don't say they're not morally defending it, but they're actually defending their position by forcing you or encouraging you through lower out-of-pocket fees to going through this elaborate labyrinth of payment systems rather than direct to the manufacturer. What would you say to that?
Yeah, a number of drugs are actually, depending on the type of insurance you have and the drug plan that you have, it can definitely be cheaper to just go through your insurance and buy the medicine. But for people that are underinsured with high deductible health plans or high out-of-pocket costs, which is about half of people that get their insurance from their job through their workplace, and if you're uninsured, you don't really have very many options sometimes. Now you can try coupons or patient assistance programs, but in those cases, a company like Mark Cuban's Cost Plus Drugs company could be helpful to you. But, there was an interesting analysis that was done of the Costco company, of Costco's prescription drug program back just a few years ago. And they looked at Medicare patients in particular, and they found that only about 11% of the time was it cheaper for the Medicare patients in Part D to pay out of pocket at Costco than it was to just use their insurance. And so, consumers are incentivized based on their cost. If it's a low cost, they're probably going to go with that. I think the tricky part that is a little bit nuanced that we're starting to learn more and more about, and that is something that I do think needs to be looked into, is what's the tiering of drugs. As you're probably familiar, when you look at your insurance card, there's often a different copay for a different tier of the drug. So there's the first tier, a second tier, third tier, and oftentimes a fourth and a fifth tier. But most people have at least 3 tiers or more. And usually, historically, generics have often been in tier 1. the lowest cost tier, which can often be, free or $10 or less. But we're starting to see that over the last few years, pharmacy benefit managers and insurers have started to place some generic drugs on higher tiers, which means that they cost more out of pocket. And so that, in those cases, it actually would cost the consumer more to pay for that higher copay than it would to go direct to consumer. So, I guess I would say, check what you're paying for your drugs and just do a quick search. I would probably check GoodRx and I would check the Mark Cuban company and see, if you may be able to get a cheaper deal somewhere else. And if it's a substantial amount, it may be worth it for you.
Well, let's talk about some of the diseases and drugs that get a lot of attention as far as being very expensive, and particularly for low-income people, almost prohibitively expensive. I'm talking about the diseases of diabetes and cancer. We've known insulin. It's a familiar drug or molecule, I guess, for a long time, and yet we hear stories about unfortunate people with diabetes who literally have to decide between food and insulin. How is it possible, given our model of generic drugs, how is it possible, and why is it that insulin costs so much to so many people?
Yeah, insulin is a great case of a lot of things going wrong in our prescription drug system. It really is. As you mentioned, it was discovered almost 100 years ago. We celebrated the 100-year anniversary, I believe, this year, actually. And it was intended to be, the discoverers from Canada wanted it to be available to everybody. And they didn't even go about making money off of it in the very early days. But what we've seen with insulin is that there has been an evolution of the product that's delivered, where there have been small modifications over the years, and monopolies and patents associated with those discoveries that have made it incredibly expensive to consumers. We just actually approved our first biosimilar, which is kind of what is considered to be the competitor to a brand name insulin ever, just recently, for Glargine or Lantus, the brand name insulin, just very recently. And before that, there was no competition for this long-acting insulin type. And so while there are some insulins that there's, I believe at least one in particular that's available over the for a lower cost at Walmart, that's called Rely On. A lot of these insulins are incredibly expensive because there is no competition and because it is a broken market. And so it's really sad and frustrating to watch patients suffer with those high costs, and especially if they're underinsured or uninsured, they're in a really tough spot. And as you mentioned, having to choose between putting food on the table and paying for their life-saving medicines.
Yeah, so again, I'm trying to tie it back to Mark Cuban's model. Is it possible then, ultimately, now that you do have a biosimilar approved, that could wind up on Mark Cuban's list of direct? Would it be possible then, ultimately, to say, look, I can cut my insulin costs by 90% if I just go directly to manufacturer? Is there any barrier that you see now that it's, in a sense, technically possible to disrupting that market profoundly with this model?
Yeah, so the tricky thing about insulin is that it is what's called a biologic, which means that it's a drug that's made using human proteins, and it is more complicated than a traditional pill or tablet, which in jargon terms we call small molecules. And so these biologics inherently have some additional complexities to production, which is part of what makes it challenging to produce. But the other part is also there are some differences in the way in which those drugs are approved by the FDA and the way in which they can be substituted for each other. All that withstanding, there is actually an interesting disruptive model that is in the works from another company called Civica RX, based out of Utah. And they have a similar sort of mindset, which their goal is, they started, I think, a couple years ago, The concept is to bypass major drug makers and to manufacture or subcontract generic pharmaceuticals. And they do it mostly, they started off doing it for inpatient medicines, like medicines you would need in the hospital, antibiotics, blood thinners, that type of injectable medicines. So they actually have some experience in doing this. And interestingly, they recently started a new subsidiary of this company in partnership with Blue Cross Blue Shield. It's called Civica Script RX. And they claim that they're working on manufacturing and distributing insulin at a really low cost. So I do think it is possible that it could happen, but just keep in mind that not all the insulins are, there are many types of insulins. I'm not sure the exact number, but I'd say at least over 20 different types. And so not only do you have to be able to make all those different types, but they also have to be off patent in order for that to happen. So those are kind of some of the challenges that any company that tries to make insulin would have to face.
So the technology is still not quite there. So, but watch this space. It may be, right. So we're on.
Sure, it looks like we're getting closer, and it can't come soon enough.
Sure. Let's talk about another expensive and well documented disease, which is cancer. I know there's a big problem. I was just reading an article in the New England Journal of Medicine about the huge difference between whether you, depending on which kind of cancer you have, if you can get it, the medicine through a pill, it's one sort of compensation. I'm talking about through Medicare. And if you have to go to a doctor to get your medicine, it's a different kind of compensation. And it really, whether you go broke or you are covered by Medicare, really depends on the type of cancer you have, which seems profoundly unfair. What can this model that we're talking about have to do with either the pill you get through the mail or the one you go through the doctor?
Yeah, it's a really interesting concept that you bring up, which really gets at the issue of Medicare Part D as that reimburses outpatient prescriptions, and Medicare Part B as in boy, which is the kind of reimbursement for infusions-based therapies through clinics. I wish there were more ways in which we could lower the prices for these cancer medicines. To my knowledge, the vast majority of them, and there are actually ways to do it, but I don't know that there's a market solution right now, because the vast majority of the reasons these drugs are expensive is because they are still brand name. And they're patent protected, and they have monopolies. And so the prices we've seen based on research that we just published recently as well, and a paper in the New England Journal recently as well, the prices of these drugs are rising precipitously. And not only is it rising over time, but it also, the launch prices, which is the initial price a company sets, can be in the tens of thousands of dollars. And so a new analysis actually showed that, as you mentioned, patients would pay up to $10,000 out of pocket for certain cancer therapies. And I don't really think, I'm not aware of any ways in which the current, Mark Cuban company or any of the direct-to-consumer companies would be able to lower those costs. It really illustrates the challenge that we have, in part because those are brand name therapies, and they are really able to work mostly on generic medicines. And so that's really an area for policymakers to intervene and allow us to, negotiate the cost of the medicine or find other ways in which to lower those costs. And that would include preventing like annual increases in those prices. So I don't know that there's much that we can do on the direct to consumer side in that arena.
How we didn't cover it at the top of the show, perhaps we should have. How long does a drug company enjoy a patent on a new drug? And you describe the thickets and the manipulation that are possible, but in theory, let's just say they're playing it straight. How long after you develop a drug do you get to sell it as effectively as a monopoly?
Yeah, so my understanding is you submit that new drug application, or the NDA, as you're starting out in the discovery process, and that patent is valid for approximately 20 years. And then there are exclusivities that get added on top of that. So it's usually 7 years for small molecules or pills or tablets, and up to 12 years for biologics. And so that depending on where you are, how long it takes for your drug to be completed, go through clinical trials, be approved, you then have kind of that remaining amount of time to market it, which research shows is about 12 years of patent protection before any exclusivities, which would add more time to that.
All right. Well, again, we like markets around here, and I'll say, whereas it's unfortunate that new drugs cost so much, a lot of that money is going to provide incentives to develop new drugs. So, there are some externalities that are favorable to the markets. But for those drug companies, those molecules or those drugs wouldn't exist. But let's shift our conversation, because we're getting close to the end of our time together, to policy. You mentioned policy. What is it that you think we could do either to encourage the Mark Cuban model to grow into other spaces, or to have policymakers educate consumers that they do have choices? You mentioned one should go online and perhaps explore alternatives. How can we foster better, let's say, understanding, more transparency, more understanding that could accelerate the market forces to drive down the cost of drugs?
Yeah, that's a great question. I think we really need to redesign the incentives in our system to ensure that the pharmaceutical distribution system is focused on delivering accessible and affordable medicines to all Americans. That is a challenge that has not really been addressed, especially for generic drugs specifically. And that includes addressing the incentives along the way that companies that are entirely vertically integrated are able to capitalize on. And I'm talking about, those companies that are insurers and pharmacy benefit managers and pharmacies and distributors. They really have a tremendous amount of power in the current market when it comes to delivering the drugs, because they not only pay for them for their beneficiaries, but they also negotiate and then supply them through the distribution channel. So I think there is a role there for policy in terms of limiting the amount of costs that are associated with distribution. I think we're starting to see that what that could look like with the cost plus drugs, where there's a limited amount of cost given on top of the production cost. But the tricky thing is this distribution is still expensive in some ways. I mean, when you look at the analysis that we did, even when you buy those drugs directly from Mark Cuban, in our sample of about 77 drugs that we looked into more carefully, it was still about 50% of the cost was to distribution, even with the low cost that Mark Cuban's company offers. So I do think the price transparency is another area where we can learn more about the specific drugs and avenues where we are overpaying and where there's an opportunity to lower costs for patients. I mean, big picture, most patients are able to afford their generic medicines without too much trouble. It really is, unfortunately, as we mentioned, the brand name drugs, and those aren't really addressed by these current types of companies. They're not really sold. So, and the policy solutions for those are different. The ones that you've probably heard are starting to heat up again in Washington when it comes to allowing Medicare to negotiate drug prices and preventing annual price increases and capping their out-of-pocket costs. So some of those reforms for the drugs that people are struggling to afford the most really do need congressional sort of redesign and action, especially for Medicare Part D, which sadly is really broken and poorly designed for patients.
So again, getting to the end of our show, do you think I'm particularly fascinated by Mark Cuban's transparency. Transparency, essentially gives consumers the information they need. Might he be creating his own market? Meaning, might there be now other Mark Cubans competing against each other, in a sense, providing consumers with all the data that they need, so that each step of the process, the distribution process, can now be competitive and theoretically compete each other out of excessive costs?
Yeah, I guess it is. I guess it is possible that other companies may pop up. You may have to talk with him and his folks to figure out just how expensive it is to be able to do what they're doing, because it does seem like a lot of work to negotiate all those prices directly with every single manufacturer, and then to work on delivering all those drugs. They do use like an online pharmacy partner that helps part of that, but I think one of the barriers is just going through that entire process. And they have some of those competitors that we talked about early on, in like Walmart and Costco. But so I guess we'll have to see who decides to join the market here and pop up.
Well, wonderful. Well, that's all the time we have. Where can our listeners read more about your work? I mentioned it in the intro before I had you on, but where can they read more about the two papers you wrote in the Annals of Internal Medicine?
Yeah, I'm happy to share a copy of the paper with you, and perhaps you can distribute that as well. But on the Annals of Internal Medicine has published these two papers, and they have been covered, thankfully, in some detail in the lay press. But I do encourage you to take a look at the actual text for yourself so you can interpret it. And unfortunately, it does seem to be behind a paywall. So I'll share with you what I can, so that way you can distribute that to folks. And they can, learn more about it through there.
Indeed. Okay, we'll do what we can to sort of thwart those who are trying to collect from our listeners. So we'll see if we can get it out there for free. Well, I appreciate you taking the time today to share with us your view. This is not an easy problem to address, but we're chipping away at the edges. So thank you very much for your research and for your time today.
Thanks so much, Joe. Hope you guys have a great weekend.
Thank you, you too. This has been another episode of Hubwonk, a podcast of Pioneer Institute. If you enjoyed today's episode, there are several ways to support Hubwonk and Pioneer Institute. It would be easier for you and better for us if you subscribe to Hubwonk in your iTunes podcatcher. If you want to help make it easier for others to find Hubwonk, it would be great if you offer a 5-star rating or a favorable review. We're always grateful if you want to help us by sharing Hubwonk with friends. If you have ideas or comments or suggestions for me for future episode topics, you're welcome to email me at hubwonk@pioneerinstitute.org. Please join me next week for a new episode of Hubwonk.